Welcome to the IFRS summary videos. These are summaries of the lectures which are delivered through Zoom platform by the International Federation of Rural Surgeons for Rural Surgeons in April last year. These summaries are just the summaries of the PowerPoints. And please have a look at the full video because there we have actual videos of procedures and so on, which make them better. Today we're going to talk about setting up the equipment for gasless surgeries. And why do we choose gasless surgeries for rural areas? The primary reason that we have been doing it is because it's possible under spinal anesthesia. And spinal anesthesia is easily available in any remote areas. You don't need the logistics of arranging gases, arranging experienced anesthesiologists and so on. And also it has less complications and it's easy to learn. And some of the procedures can easily be done with a single incision, unlike in regular laparoscopic surgeries, where it is more difficult to do single incision surgeries. And we have done a fair amount of gasless cholecystectomies, appendicectomies, hysterectomies, ovarian cystectomies, infertility surgery, and even some hernia surgery. So this is probably the ideal way of providing minimally invasive surgeries for rural areas. If you look at why these gasless equipment is developed, you'd find that it started in the early 90s, primarily because they found that pneumoperitoneum does have some complications. And even the laparoscopic surgeries have a small but definite complications. So what happens is that when a patient is not in good condition, so the physiological changes can adversely affect them. Again, you need experienced anesthesiologists who need to manage all the physiological changes. So people are looking at alternatives, and they found gasless surgery to be an ideal alternative. This is probably the first device which was made. And Dr. Hashimoto is called the father of gasless laparoscopy surgeries. But as you can see in this picture, it's a fairly complicated machine, and it's not always very comfortable to do the surgery through this method. But then it is a good start because it avoided the various complications, no physiological changes, and so on. And then these are some of the early devices which look fairly complicated, but then they were primarily designed because of the physiological advantages. And most of them started because Dr. Hashimoto was from Japan. And then a wide variety of instruments came into existence. This is the Shrikande device in India, then the Damini device, the Tintara device. The problem with these devices is that, as you can see, there is tenting because there's a rod or something which actually lifts the abdominal wall. And the space available for operating is fairly limited. So it is a little difficult to maneuver and arrange the equipment. So then they started devising motorized devices. But again, this only helped a little bit because the movements are much easier. But then again, the tenting was there and the exposure was fairly limited. And then they came to a different mechanism. There are two plates which are inserted in the abdominal wall, and then it spreads. So this is a device by Dr. Dakshinamurthy in South India. And then later on, people developed Laprofan. Again, here it was an improvement from the tenting there. But then exposure was not adequate. And unless it's absolutely indicated, people are not willing to use the device. Then other motorized devices came into existence. Again, similarly, having a spread at the tip. And these motors help to maneuver around. And this is the next stage where they had a flat thing in the front, and also to provide additional lift. These sort of wires were used. But again, although it is an improvement from the original devices, it is not comfortable to operate with. And again, it takes a long time to set up all this equipment. Then the next stage, of course, is they went on to the motorized devices, which are better, but then again, not as good to replace conventional laparoscopic surgeries. This is another device where there's a balloon and you operate inside the area. But then the first device which apparently gave a good exposure, a device by Dr. Daniel Kruszynski in Germany. Here it is a ring which lifts the anterior abdominal wall, at least half the portion of the wall. This gives an exposure, especially in thin patients, almost similar to conventional laparoscopic surgeries. The equipment that we use a modification of this, which allows for quickly to set up the equipment and start operating. And this, of course, has helped us to do a lot of single incision surgeries. But one of the limitation here was that the ring, although we initially made in 3 sizes, we used this particular middle size because you need to make sure that there are no intestines between the abdominal wall and the ring. So we used the finger to sweep around to check that before lifting the thing. Because you don't want the intestines to caught between the ring and the abdominal wall and get crushed. So this was the limiting factor. Again, the thickness of the wall also matters because you need to lift the wall. So initially we felt comfortable operating with patients with the BMI of 25. And later we could comfortably operate till a BMI of 28 or 29. Now, of course, with the experience, even the trainees have operated on patients with the BMI about 30. And there are several modifications that were made as experience improved. Because there's a cut to prevent the ring from slipping. Sometimes the whole apparatus can slip and fall down. And there were difficulties if there was addition. So there were quite a few changes which were made. And ultimately, the advantage of that, these click locks that you can see here, made when allowed for plenty of movement and quick fixing with just 2 click locks. And the ball and socket joints which are here provided so much movement that you can almost place it at the convenient place where you want. So you put the lift, place it in a convenient place, and then lock into position with just 2 clicks. And another problem was that the gear system, the whole, because of the weight, the whole apparatus used to come down. So then special arrangements were made in the gear system to make sure that that does not happen. And this is one of the slides which is probably not there in the original lecture. This is because what we need is a global surgical device, which means that the device that we have should solve the needs of the people in low resource poor setting. Because here the people will have fluctuating power sources, there will be few trained staff, locations will be remote. So whenever we devise anything for these setting, it needs to be adaptable to all these conditions. So then the University of Leeds group, they helped improve on the first generation of lift device. with what is called a frugal innovation and a participatory design method, where all the trainees were brought together and they gave the advice on what are the necessary improvements. So the biomedical engineers and the doctors work together to improve on these equipment. And then finally, this is the second generation of equipment which they come up with. Although this has not yet been used in clinical, cadaveric trials have shown that is as good, if not in some ways better than the original device that we have been using. The original video, you can see how these equipment is set up and removed, and you can do the surgeries. And as mentioned earlier, these are the surgeries that were carried out. And another thing which we need to work on is the hand equipment which you use for surgery, especially if you're doing single incision surgeries. We need to make a lot of modification. The advantage with the gasless is that it can have any type of design because no need to worry about the gas leak and so on. Now we'll just have a quick look at the simulators that we use for training in gasless surgeries, because it's important to learn how to convert 2D images to 3D actions before we actually start working on patients. In big centers with a huge turnover, there is a possibility of learning all this in real time and on patients. But in rural areas with the low turnover, you need to practice these skills much earlier so that you're comfortable to do the surgeries. This is the Innovis simulator, but as I expected, these conventional ones are quite expensive. But then there are many devices, boxes, basically, which are available in the market, which can help you to practice. The University of Leeds project again devised a very low-cost device for practicing laparoscopic surgery, which is very lightweight, and it actually folds into a small box and could be assembled in 10 minutes. And another big advantage is that you don't need a special big monitor. You can connect to Android phone, laptop computer, iPad. And the studies which were done comparing the expensive Innovis simulator with this low cost has shown that both are similar and there's no significant advantage in using Innovis simulator. But then, especially during the lockdown period, it's not possible to get even the low-cost simulators. So if you're keen on doing it, you can even practice in just a cardboard box with the ordinary cell phone. The camera of the cell phone is good enough to practice. And if you don't have anything else, you can just use a thread and the thread holder to practice the various skills. And what are these skills that you need to practice? The Fellowship in Laparoscopic Surgery Training Program is a well-validated program offered by SAGES. And it gives these tasks and the timing in which you need to master the task to perform, like peg transfer. You need to pick up the one instrument, change it to the other instrument, and put it in the other side. This has to be completed in 300 seconds. Then we have what is called precision cutting. You need to cut along the circular line. Then you need to practice extracorporeal knotting, then intracorporeal knotting, and suturing. And these are the timings which are given. And there's proof that if you do well in these tasks, it translates to better performance on patients. But again, you might not have these simulators and these disposables that you use for practicing FLS tasks are expensive and not easily available in any other rural areas. So we need to look at what we are trying to achieve. So what we need to do is to convert 2D images to 3D actions. So we need to know how to do that. Then of course, extra intercorporeal knotting, suturing, and dissecting and cutting. It is the same skills that FLS teaches. So if you need to buy just one of the disposable items which you use, it's good to buy the peg transfer thing. So you can use a Maryland and needle holder to perform most of the tasks. And you can practice by keeping it in various places at different angles and so on to convert 2D images to 3D actions. Then the extracorporeal knotting, you can make a endo loop by any thread. Either ideally we have a thread like proline, then it makes it easier. But even ordinary thread, it's easy to make modified rotors or fisherman's knot and put it inside the pusher that we have for double J stenting to make a low-cost endo loop. As you can see, this is a low-cost endo loop, and you can practice tying it on stuffed gloves, which sort of simulates how you would tie and remove an appendix. And then the pushers, again, are low-cost. The two types of pusher, for extracorporeal knotting, you can use either ordinary knot and use a pusher leathers, or a fisherman's knot and push it leathers. You can see the videos in the actual lecture. And then if you're doing single incision laparoscopic surgeries, you need to practice how to do tying knots. So there are several videos in the main lecture which will help you to learn how to tie these knots. The principle is that you keep the shorter thread below the longer one and then loop it up and put it inside the loop and pull it in that side. But then it needs a lot of practice, and once you practice, you can dramatically reduce the time you take. And there are various methods of tying this knot. There are not just one method. So whatever you are comfortable with, you can choose to learn and do that. You can also use the needle to tie. You can keep rotating. So whatever you're comfortable with, you need to practice and practice again and again so that you become familiar and comfortable with that. So we have shown about 4 or 5 different methods of doing this knot, especially in single incision. And again, suturing is another important skill that you need to learn. Instead of buying the expensive disposable, you can just stretch a gauze piece and do the suturing. And this will help you to not only learn suturing, but also learn how to tie knots at the beginning and at the end. So this shows steps. And another important skill that you need to learn is how to hold the needle holder in the correct place. There are again various methods of doing it. You hold it and then pull it up and hold it, or just press it down and hold it, and so on. These also you can go through the videos in the full lecture and learn how to do it. And this is another method of drawing over a stuffed gloves. This even offers advantage over the conventional disposable that FLS programs give, because here the line is in a 3-dimensional fashion. It's not in one plane. And you don't have to draw a perfect circle. So trying to cut these with the scissors gives a much better practice of how to do precision cutting. And we have used methods like putting up Velcro patches and try and dissect to learn how to dissect. And of course, as we said in the beginning, even if you don't have any simulator, it's possible to practice these skills. And once you practice these skills, you are ready to go and do single incision or gasless laparoscopic surgeries. And in the later videos, you'll know how to do the various surgeries. Thank you.